So I will hand over now to Georgina, who will talk about the rationale and the evidence behind group clinics within primary care.
Hi, everybody. So I'm just going to keep this very short. And I should also say that the rationale for group clinics also exists within specialist services as well as primary care. But let's have a look at some of the evidence in primary care. So it's really useful to think about where group clinics work and where they probably aren't going to be appropriate. And the way to think of this is group clinics fit particularly well into care pathways that are planned and routine and driven by guidelines and protocols, and often where there's an element of self-management or rehabilitation as part of the intervention. That's really important in relation to the 10-year plan, because a lot of the care that needs to have a preventative angle, so the shift that is signaled between from illness to prevention, are going to be suitable for a group clinic model. What it is less helpful for is looking at patients where you're obviously in an urgent situation, where you've got a lot of very detailed history taking to take, and where there's a lot of uncertainty and a high level of risk. And the good news is that by doing the more simple clinical work using group clinics, you're going to free up clinician time to deal with that more complex work. So, for instance, thinking about waiting times, if we can make our routine follow-up appointments more productive and efficient, then we can deal with those urgent patients who turn up at the door. So it's a way of improving access. It also has being seen and followed up in group clinics and supported to self-manage has a positive impact on self-management as well and self-care. So patients also make more behavior related changes when you see them followed up in a group clinic compared to one-to-one appointments. So that's really important, because we know that the way forward to support the NHS to be more sustainable is for patients to keep themselves more healthy. And that's one of the reasons why group clinics are seen as part of a lifestyle medicine approach. They are already being promoted as a solution to a personalised care approach to long-term condition management by NHS England in its modern general practice document. And in this context, you will see they are referred to as shared medical appointments. A shared medical appointment is a term that is used in the literature. It's not used in clinical practice. But we're talking about exactly the same thing as Alicia has described to you. Next slide, please. And there are other benefits as well. So in terms of delivering those kind of pathways that I've described, those simple care pathways, we see an increase in compliance with protocols and guidelines like QOF. Often that care is delivered by nurses, and we've got good evidence that the group clinic model frees nurse time. So you could expect to save a 0.5 full-time equivalent nurse for every 500 patients that you review in group clinics. And also, compared to one-to-one appointments, there's evidence of improved outcomes, particularly in diabetes, for HbA1c and blood pressure improve, quality of life measures improve, knowledge measures improve. Patients report they feel a greater sense of trust in their clinician and are perceived the group clinic as a higher quality care experience. And there's a positive impact on patient satisfaction and experience of care. And that goes beyond the patient. It also impacts positively on nurses and others' experiences of delivering care, because the group clinic model provides autonomy to redesign what can be quite repetitive care episodes. It creates a really deep connection between clinicians and the patient, and clinicians always tell us they they get huge amounts of insight and really build empathy and respect for their patients when they hear their lived experiences. And all of that really instills a real sense of joy into clinical practice, which is sadly missing a lot of the time right now. And we would expect that this would have a really positive impact on retention, which is critical right now in the NHS and particularly for nurses. So with that background described for you, I'm going to hand over now to Sharon to take us through. I've been working with Sharon for about 3 years to embed group clinics. We were talking earlier and saying it was just during COVID that we kind of started to work together, wasn't it, Sharon? And
Yeah,
Sharon is a nurse, and I know that she's going to share her own personal reflections as well as share a really powerful evaluation that really has illustrated the benefits of group clinics from a whole system perspective. So over to you, Sharon.
Thank you, Georgina, and thank you for the opportunity to highlight this. As Georgina has said, I am a nurse and I do still work clinically at weekends in the primary care arena. And as Georgina said, I started to become aware of this during the COVID pandemic, and it was virtual group consultations. There was a little bit of funding floating around for the opportunities of this, and I connected up with Georgina. But as a clinician, as a nurse, I could see how this concept could really support the patient journey and the patients that I was seeing. And some of you may recall, you know, the expert patient program. And I just thought, you know, this is a really fantastic advancement on that. And so I really thought, I need to embrace this. I need to highlight this to colleagues. And so I went off on a mission, didn't I, Georgina, about highlighting this. So the thing that I loved about it was that it gave that, and Georgina reflected on the you know, the benefit that the nurses found in retention, but it really supported that leadership element of the nursing journey as well, in that leadership in terms of that patient pathway. Because as a practice nurse and as a primary care nurse for over 30 years, you know, long-term conditions management was something that was my bag, basically, my focus. And to be able to take that one step further and to innovate in the practice was just a fantastic opportunity. So yeah, so I'm gonna stop wittering on about my journey and just, you know, deliver. So I wondered if we can go on to the next slide, please. Thank you. So the Kent and Medway group clinic program overview. What I was really lucky at, because my day job is around primary care workforce development of the primary care workforce, was about supporting teams to get trained to deliver the group clinics. And that offer has been available since 2020. And the funding, originally there was funding coming down from NHS England, but since then I've been able to, you know, sell this concept and the benefits of this concept to the ICB and to the primary care transformation teams. And I've been able to secure funding through them as well. And I think partly because I've been able to describe it from a clinical perspective as well, which has really helped. So it was, as I said, during and immediately after the pandemic, the focus was on video group clinics, but since then it's obviously evolved. So since 2021, there's been intensive support that's been on offer, include training and live coaching that we within the training hub have been able to advertise across our Kent and Medway practices and raise awareness of. And so it covers both face-to-face and virtual group consultation models. And obviously each PCN or practice can choose their preferred delivery route, basically. And also they can determine what they would like to pilot, because the one thing I would just like to highlight is that this is a journey. So if you're in an area where you're just embarking on this, you know, we've been doing this for a few years now, so it's taken this long to really start to see the real benefits and the innovation that's going on as a result. And so, you know, it's not going to happen overnight. So I just wanted you to be aware of that. So and it was about, you know, making people aware of what the program is, and today is a really good start. especially for those that have not done it before. And obviously the training, there's some simulation training, and then that advanced skills training, that is usually specific to roles. But what's been great about working with Georgina and the team is that ongoing support that they've been able to facilitate. So it's not just about getting the training, that's that intensive support to operationalise it and also be that point of contact, because, you know, I've been badgering Georgina for a long time now. So, okay, next slide, please. Thank you. So the implementation team has leads from 9 teams who have been registered on the intensive support programme for at least 5 months were contacted, because what I wanted to do was to demonstrate the benefits realisation to our commissioners and to the wider team about the benefits of this and why I need further funding to continue this, and the impact that it's having on patient outcomes, because it's not just about increasing access, which is important, but it's about the impact that it has on the patients as well. So I linked in with Georgina, and we were very pleased to be able to do this review to find out the impact. So Georgina contacted the 9 teams who were working at the time and had operationalised this, and 8 of those teams agreed to take part. Sadly, the 9th team, the lead for that was on annual leave at the time, and then they were free to nominate interviewees, people that Georgina and the team could ask, you know, their perceptions and their feelings on the benefits of this. So between the 17th and 29th of October 2024, 10 interviews were undertaken with those 8 teams, and Georgina and the team were recording them so that they could get that feedback as well as transcribing them. Now, these interviews took place between about 34 to 45 minutes, so it was, you know, quite an intensive discussion that they had, and were able to drill down in some of the questions, and they covered excuse me, personal and team experiences of implementing those group clinics either in the practice or the PCN, basically. So we really wanted to get a feel and a flavour, because what I wanted was to be able to say, as I say, demonstrate the benefits realisation for both the patients as well as the commissioning teams, and also for primary care in general. So next slide, please. Sorry, I'm just going to have a quick drink. Sorry about that. I've been talking too long this morning. So all of the teams had completed the recommended training, which is fantastic because, as I said, it was fully funded and available. There were 14 different clinical and non-clinical roles engaged as part of the team. So you had a mixture of multi-professionals. And as you can see, I'm not going to read them all out for you, but you can see it covered the multi-professional primary care team. And at the time, 5 teams had gone live at the time of the evaluations, and 3 were close to going live. One team in particular had faced challenges with estate limitations, but the team hadn't actually trialled the virtual group consultation process, but they were in the process of considering that in the light of the review that was going on. Now, I mean, it's not rocket science to me as a clinician. I thought it was just fantastic, but they agreed with me. 100% of the teams believed group clinics could improve patient experiences of care, because, as I said, I could see how that would work. 88% of the teams believe group clinics save team time. One felt and believed the impact was time neutral, but, you know, I mean, without drilling down, it could be that they were in the early stages, but, you know, either way, you know, that time release was a key element, but partly because the number of patients attending their virtual group clinics remained low, so they hadn't seen the full benefits of, you know, as I said, so they were in the early stages. The team recognised this was also impacted by the way the receptionists sold the group clinics, so that was something that, you know, I became more aware of also as to how we describe this to the wider team, and in particular the reception staff, because when patients are booking appointments, and that's something that Georgina and the team go through, when people are booking clinics, whatever wording the receptionists are using, patients are, you know, taking that on board as well, aren't they? So there is some training for the whole team. So teams rated group clinic trainings impact as 9 out of 10 in being extremely important, because it enabled that facilitation of their skills and confidence to make that change. And it's that change management process, isn't it? It's how you embed that change and take that forward, because change is sometimes quite scary. So it's not just the clinicians and obviously the patients as well. So that change process is key as well. But 100% would recommend the training and the participation in the programme to other teams in Kent and Medway. So this was all of the evidence I need to be able to go back and showcase this. And I started sharing this far and wide and saying, you know, your peers are saying this. It wasn't just me, it was the peers that were sharing this as well. So if I can go on to the next slide, please. Thank you. So to summarise on that, the key impacts were the impact it had on access and waiting times. Waiting times were coming down, and patients, it was increasing access to the clinician, to getting their appointments, to getting their reviews. Improved quality of care was highlighted as a key impact as well, and they were able to demonstrate that. The workforce development, as I said, you know, speaking to a few of the nurses in particular, that leadership element, they were given this to lead on, and it really helped them feel empowered and able to support their patient journey far greater. And you know, some of those nurses have gone on to develop further in that, so it's been a fantastic career development opportunity for them as well. The patient experience, the feedback from them and the staff was fantastic, and if you get to, you know, see the report, it's worth noting. And I know the national review of group clinics, they have referenced some of the work that was going on in Kent and Medway, because it was it did exactly what I thought it was going to do. It demonstrated exactly what I thought it was going to do as well. So it was just fantastic. You can see I'm passionate about this, can't you? Sorry. Next slide, please. So if we talk about the access and waiting times, group clinics have, this is in the teams that we had, reduced waiting times for appointments, so less than 1 week's wait for a menopause appointment, reduction in wait for post-diagnosis diabetes appointments from 2.5 months to 2 weeks, improved productivity, 8 group reviews in 90 minutes compared to 3 one-to-one appointments in the same time frame, released GP appointments. Practices that had implemented the menopause group clinics, for example, recognised it had released one-to-one GP appointments at a time when we're trying to increase access in primary care. It's just fantastic, isn't it? It provided a sustainable way to integrate prevention, lifestyle medicine and personalised care into routine clinical practice. So care episodes take less time per patient and create time for in-depth discussions about lifestyle and for preventative work as well. And that's, you know, part of that, you know, the NHS 10-year plan, you know, illness to prevention, you know, it's shifting that mindset, isn't it? It's shifting that focus, and this supports that. It also provided a place for external experts to engage with patients. So the public health team attended one practice's social prescribing group clinics, because we had social prescribers leading on some of that as well. So it just created that opportunity to be even more innovative as well. So and that was fantastic, that one. So okay, so improved care quality, more consistent quality of care and advice. Basically, group clinics mean that those with the greatest clinical expertise consistently review and assess patients for menopause. So those, you know, the time pressure on those that specialise in a particular area, by having those group clinics, it, you know, it really widened the opportunity for that access. The improved quality care. Clinicians perceived that having peers present at assessments and reviews led to higher quality clinical care, and that the 90-minute group clinic sent a clear message that the patient's health condition was serious and the team was investing time to support them. And we found that in diabetes and menopause. And positive impacts on biometrics. A specialist diabetes nurse reported that she was already seeing a positive impact on key biometrics in newly diagnosed diabetics after just a few months. And this links with the fact that group clinics create time for discussion of prevention and lifestyle changes. So it's just that. And also, you know, the thing that we haven't got measured here was the, you know, having a group of patients in one room. Why is your HbA1c better than mine? What are you doing different to me? It's that peer-to-peer element as well, isn't it? So I just, you know, I thought that was interesting hearing from patients about that. So time for informed. Oh, sorry, I hadn't finished off. Sorry, I'll I'll just finish off. Sorry. Time for informed decision making. Clinicians recognise that 90-minute group clinics provide the chance for patients to reflect and voice their concerns, and also hear from their peers and come to that informed decision about preferred treatment. And they'd hear, you know, other people's views and perspectives, and it just enabled the clinicians to have a deeper insight into the patient's lived experience by hearing some of that as well. So I just, you know, I you know, passionate about this, and can see, you know, the benefits the patients gained so much from exchanging ideas and co-producing solutions to these challenges together with their peers as well. So if you go on to the next slide, please. I'm hoping I'm not going over time for this. So workforce development, the team impacts. A workforce development tool that supports collaboration and integrated working across a wide range of clinical and non-clinical team members, and with the focus on neighbourhood health and neighbourhood teams, this really supports that as well, because you're pulling in your wider health and care colleagues with this. And it's a way of integrating and harnessing skills of additional role practitioners. So we've been able to demonstrate that clinical reviews for pharmacists, you know, having pharmacists looking at cardiovascular and hypertension, that type of thing, has been, you know, an interesting journey to watch, and enabled care coordinators to take ownership of that patient pathway management. Primary care team cohesion and resilience. Nurses and health coaches have learned so much from each other in doing this. And that's the thing, we don't always understand each other's roles, and what the group clinics has done is built on that. That multidisciplinary quality improvement, you know, that improvement as planning has worked well because everyone has contributed within that, because we all bring specific skills to that, don't we? And that digital maturity, virtual group clinics have built a whole team, and especially GP confidence to deliver online care as well. Because during the pandemic, when that virtual consultations came in, I mean, I certainly was a little anxious about that as well, as I'm sure, you know, some of you may have been, but this has enabled that confidence building as well. So that support for women to improve menopause management. When one team introduced menopause group clinics, it ignited their passion for the subject and motivated them to build on their group clinic and create a menopause awareness initiative aimed at practice staff as well. So the patients didn't just benefit, the staff did as well. It really developed further. So thank you. Next slide. I'm nearly finished, I promise. So the individual impacts, clinical autonomy. Clinicians recognise that clinics have restored autonomy to routine clinical practice, especially when led by the practice nurses. They felt that this was, you know, real. They were taking a lead on this, obviously with their senior colleagues, but they really enjoyed the opportunity to be able to do that. Realising the benefits from investment in health coaching and lifestyle medicine accreditation, you know, that shift from illness to prevention and that lifestyle medicine approach. Clinicians who gained accreditation were able to use acquired skills and knowledge more easily in group clinics as well. I know Mark's going to be on the call shortly as well, so I'm looking forward to hearing his perspective as well. It developed implementation leads and their change management skills and experience, and as I said, that change management approach, they gained leadership and change management skills, which they've used in their role, in their wider role as well. So personalisation transferred to one-to-one care. Group clinics have built clinician trust that they can cover all of their clinical tasks and let patients' concerns lead discussions. You know, it's been that shift, and watching that has been fantastic to see as well. So next slide. Challenges. You can't do anything without having a few challenges, and that's completely understandable. And then it's how you develop from those challenges. Sustaining the facilitator workforce. Trained facilitators are critical to sustaining the switch to group clinics. So recruiting and retaining the facilitators has proved a challenge for several teams over time. And when adopted more widely, group clinics will impact significantly on the primary care workforce requirements. So it's understanding how these roles are evolving in the same way that reception staff's roles have evolved. This is a similar journey, isn't it? And engaging the primary care nurses. So several implementation leads recognise that primary care nurses are often sceptical about group clinics. I mean, I was quite lucky that I didn't have that, but I can understand where they were coming from. And their preference was to often stick with one-to-one appointments. So even when one nurse was keen, others being skeptical could hold them back in the team. So I would certainly say it's about linking in with the wider team and speaking to people who've already done this, speaking to colleagues who are already doing this, because it enables you to see it from their perspective as well. So, and building those nurse champions can help overcome this. So if you've got people that are passionate about this, really harness them to do that. So next slide. So patient experiences, just to give you a bit of feedback from the patients, this is what they felt. It's built trust in and connection between patients and clinicians, improved the quality and continuity of care. It was that continuity of care that they really loved. And it had a positive psychosocial impact through peer support as well. As I said, I remember the days of the expert patient programme. This is evolved from there, and that peer support has been fantastic. It's supported holistic person-centred discussions in those clinics as well. We've seen that. Created a new power dynamic in that, you know, the patients are leading this as well. So it's you know, it's not the, you know, the what do they call it, pedagogy, the teacher telling. It's that andragogy. You've got that adult learning as well. Improved information and retention and comprehension, because they're in a group and they're saying, oh God, what did she say about that? Or so they're talking to each other as well about this, but it's enabling them to understand it better, because you're not bombarding them in a 15-minute appointment. It's a longer appointment where they're able to take their time as well. It's definitely empowering patients, and that's supporting that informed decision making to their care as well. So next slide. Staff experiences. You know, I can, you know, agree with everything on here. Led to less repetition and more productive clinical practice. I was saying the same things over and over again in some of my diabetes clinics to these patients, and you're reducing that repetition and you're doing it, and you've got more time to do it as well. So, you know, it really does become more productive longer term. It energized the whole team. You know, this innovation, you know, the whole team were keen to take it on board, and just to see them flourish has been fantastic. And that rapport with patients, which is deepened as a result of it. The personal reflection and and the team focus on, you know, personal well-being as well has been fantastic. And what it has done is that it's helped practitioners embrace their fear of change, because it's like, oh God, we've got to do this, and this is a change to the way I've been used to working all of this time. But that reflective practice, because practice makes perfect. You won't get it right first time necessarily. You are on a journey with this, and as we are reflective practitioners, we're constantly thinking, that didn't go as well as I would like. How do I adapt that? How do I learn from that? Because it's a learning environment that we're in, isn't it? That we can, you know, get it right and get it better for the patients. And it reconnected teams with their core values as well. You know, the patients, you know that you know, we're there to provide the best high quality care for our patients, aren't we? And this helps you to do that. And it definitely supported team resilience, because there was increased capacity in the practice for these teams. So definitely supported that. So I think I'm nearly finished now, aren't I? So okay, so do you remember what I was saying about that? You know, the NHS 10-year plan and how it really supports that. So if you're thinking about the shift from hospital to community, group clinics are definitely a vehicle for integrated neighbourhood working, because it facilitates those partnerships with local authorities, social care, voluntary organisations, and integrating health and community services. And if you think about the social prescribing link workers, that's a really good example of that. It increases clinicians' capacity and access. You know, so if you're shifting more out into the community, you're going to need that access. And it definitely reduces the waits. You know, I'm thinking about QOF and things like that, you know, getting those patients through. It really does support that mobility. I'm thinking about, you know, using the technology, you know, analog to digital. You know, it's a more engaging way to deliver digital care compared to the one-to-one video consultations if you're using that virtual group consultation approach. And it's a digital skills accelerator for everyone. And as you saw, a lot of those nurses in particular, you know, it built their skill set. but the focus of illness to prevention, you know, enhanced personalized care experiences with the time for prevention and lifestyle medicine, as we mentioned. It's less paternalistic than traditional appointments, and it encourages patients to take an active role in their health. You know, it's shifting the focus on the self-care element. There's a greater impact on behaviour change, and you've got that group as well supporting you in that. You know, in integrating social prescribers and those community resources within that as well. And certainly one of the teams where the social prescribers is leading on this has been fantastic. And I think for me, the first time I came across this, I could immediately see how managing long-term conditions effectively in the community could be done by group consultations, and they can reduce unnecessary hospital admissions because you've got that support and you're able to give that support to the patients more readily, and it's supporting people to stay healthier at home. So, you know, for example, diabetes group sessions often cover sleep, physical activity, stress management, and social isolation, which you may not have the time to do in a normal one-to-one type clinic. So it's empowering patients to make healthier choices and prevent the complications. So this really does support, and hopefully nationally they will see how this will really support the 10-year plan and really shift that agenda along. But I think I've said enough now. I just think it's fantastic. So thank you for the opportunity.
I am going to just move us on, if that's okay,
Yeah,
Sharon,
absolutely.
just from the point of view of time. So we're going to move to Mark now. So Mark was actually his team was one of the teams that was involved in the learning review. So Mark, over to you.
Hi, thank you very much. So I think it's helpful if you're thinking about doing this kind of work just to hear from someone that's done it and made it work, because it can feel quite intimidating to start with. So I've got some slides. A lot of it's been covered in terms of evidence and things in really good detail. So some of it I'll just skip through, but what I want to give you is just a brief idea of how we've done it, why we did it, what some of the outcomes were. So this is why we did it. So the problems that we had are probably similar to the same problems that many of the rest of you have in primary care. We have a growing list of patients with diabetes, which is a national, local, global problem. We were trying to do this in a time of decreasing resources in primary care. We found at our own practice we were having issues with unsatisfactory HbA1c outcomes, and that had impacts on not only patient care, but also QOF. So if you're thinking of this from the point of view of a partner or a commissioner, then actually what you're wanting to do here is try and provide a service which gives good patient care. And the positive side effect of that is that you get better data as well. So coming on to the next one, please. We can skip over this as well. One question that always comes up, I will just mention on the last one, is that indemnity, it is covered under the normal Crown indemnity, or whatever you want to call it, the CNSGP. So that's often a question, so I'll just cover that now. So in terms of the sessions that we do, the reason that we wanted to do them, one was just the evidence around the fact that they work very well. There was lots of evidence that there were improved clinical outcomes, that there were better outcomes in terms of staff satisfaction with presenting them. I think one of our real triggers early on was speaking to our diabetes nurse after a whole afternoon of diabetes appointments, and she was just sort of exhausted and defeated at having to do the same thing over and over again in these brief appointments with people. And she felt there might be a better way. That was one of our early catalysts for doing it. So it showed improved patient outcomes, improved staff morale, and there was good evidence of improved efficiency gains as well by doing it. So thinking of this, one, as a clinician, I'm looking for things that are going to work well for my patients. Two, as a partner, I'm looking for things which are going to be efficient for the practice. And three, from coming from a previous sort of commissioning role, which I've had in the past, looking at how can you implement changes at a practice level which improve patient care and improve efficiency. And that's always tricky to do from a commissioning point of view. That's almost the holy grail. How do you tick both of those boxes? And this seemed to be one of the ways to do that. So the actual session itself, it's as we've discussed really already, but 10 patients can come in per appointment. We tend to average a bit lower than that at the moment, but we can still have scope to build up from where we are at the moment. The session is opened by the facilitator. That job has been done by 2 different people in our practice. In the past, it was done at one point by one of our health and wellbeing coaches, which is a PCNR's role for us locally. And then now it's done by one of the care coordinators. They open the session, take the key concerns and questions, and then we have a diabetes practice nurse that joins the session. This then opens up a group discussion. It's very much patient-led, and there's common themes which come up in all of these sessions. Really, the common things are medication, lifestyle changes, medication complications, worries and concerns. As already mentioned, one of the real benefits is that patients can see each other's successes and also support each other in their setbacks. So if a patient has succeeded in a certain dietary change or has managed to start a different medication without concerns, then that can be discussed between all the people in the group, and it sort of removes some of that stigma and some of that mystery from how the treatment process works. At the end of that session, the nurse leaves, finishes the admin and does the notes. I think I saw one question in the chat that came up, how the notes done. It's done basically in the same way that you would do for a normal one-to-one diabetes appointment. We use Arden's templates, so they're quite quick and easy to fill in and efficient. Okay, next slide, please. If we can skip over this one, thank you. At the moment, I just re-audited this the other day. So we've got some data. We haven't got a huge level of sort of data on lots of things, but we do have numbers. We have the 26 group sessions. We're averaging 6 patients per session. And we've found that there's a 45% increase in efficiency. So what I mean by that is in the amount of time that we can see 145 patients, we previously would have been able to see 100 patients. So you can see that in itself, if you're thinking about how to best deploy your workforce, that in itself is a huge gain. And I think, personally, I think we've probably still got quite a lot of scope to increase on that. The fact that we've done 26 sessions highlights one of the risks in this system, which is that if you've got one really good practice nurse and one really good facilitator, and one of them goes on maternity leave or is unwell or leaves to work in a different practice, then that is a risk. So that's something which you need to think about and have a backup plan for. Our diabetes nurse went on maternity leave during this, so then we had to get a new one. So that slowed us down a little bit. But I think still having done, on average 1 every fortnight and having those efficiency gains shows that it's successful, but definitely room for improvement there. We've asked patients for their feedback. This is from our initial pilot from the first 3 months, so this isn't up to date, but I can't imagine it would have changed greatly. We asked patients, a bit like we did on this session today, how confident before the group they are and how confident afterwards. And you can see their confidence score out of 10 goes from 5.6 to 8.3 out of 10. And asking patients if they would recommend it to family and friends, 97% answered yes. Next slide, please. And then in terms of how the patients find it, I mean, there's various bits of feedback you can read there, but the common themes are things around people feeling less isolated in their chronic disease, people often feeling a little bit skeptical beforehand or a bit nervous, but coming out feeling like it was very much worth it. And then there's some practical things that people have learned as well, along the lines of dietary changes, other medications that can affect them, and just that sort of camaraderie that they had as well. And I think one more slide. So my advice really would be, if you wanted to get started on this work, would be just to get started in some small way. Try not to be overwhelmed by the task at hand. There are a few issues around space. So we're fortunate that we've got room to do it. But if you're in a very small practice and you're already struggling for space, you might find that difficult. If that's the case, you do have the option for virtual clinics, which we haven't done, but I know that we've talked about. Patients need lots of information in advance. What they don't want to do is turn up to what they think is a one-to-one and then be finding themselves in a group clinic. They don't like that. So make sure patients are well informed beforehand. There's lots of information about confidentiality, standard operating protocols and things all on the ELC training. I'm not affiliated with ELC, but we did use them and we found that to be all extremely helpful. Sometimes clinicians don't like the idea, the fear of public speaking in front of people. I think the more they do it, the more they just sort of get into it. And if you start small as well with 3 or 4 patients and then slowly build up, that's easily overcome in my experience. Yeah, I think the others speak for themselves. So if you just go forward one more, I think. Yeah, so I think overall what I'd say is what you need first thing is to get buy-in for the leadership within the practice. You want the clinicians and the admin team, as has already been mentioned, to understand the merits of it and the benefits of it. You need to find a space and you need to find out when you're going to do it and where you're going to do it. You need to get the adequate training before you start, because that demystifies an awful lot of stuff and will give you a lot of confidence. As I say, start small, but just start somewhere. And as has been mentioned as well, review after every meeting, work out what worked well, what didn't work well. And just be prepared for the fact that, you know, sometimes it won't go well. People might turn up and not be happy with it being a group, or somebody may hog the conversation. But I think we deal with these sort of, you know, challenges every single day in primary care, even on one-to-one basis. So there's nothing unique about groups, which is more anxiety provoking than just normal one-to-one consultations, really. So I think people often have lots of questions, really. I know lots have been asked in the chat, and I've not been able to read them as we've gone, but if there's any common questions which you'd like me to answer just to help demystify, then I'd be more than happy to do that now.
That's brilliant. Thank you so much, Mark. I've been prompting people to pop questions into the chat whilst we've been talking. You and Sharon have been talking, and I'm going to encourage them to continue to do that. We're a little bit short of time. We've just got 5 minutes left. So if you have got questions, please pop them into the chat. But in the meantime, I think we might just start to bring the session to a little bit of a close. So